The last panel for the day, and definitely not any less interesting. Strengthening healthcare provider systems to mount effective response to shocks while maintaining core functions and sustaining essential needs. Dr. GVS Murthy, Director, Institute of Public Health, Hyderabad, is the Vice President South, Public Health Foundation of India, and he's also a professor of the Public Health, Eye Care and Disability at the London School of Hygiene and Tropical Medicine. He helped in establishing the first Department of Community Ophthalmology at the Dr. Rajendra Prasad Center for Ophthalmic Sciences, New Delhi, and later helped in setting up the South Asia Center for Disability Inclusive Development, Hyderabad, which is a center of excellence for the public health disability. Dr. Murthy completed his MBBS from Guntur Medical College, MD from All India Institute, and his Masters in Community Eye Health from the Institute of Ophthalmology, University College of London, with a distinction. Dr. Murthy has been ranked amongst the top 2 research scientists of the world by a study conducted by Stanford University, USA in 2020-21. Request Professor Murthy to please come and take the dais. Dr. Krishna, Reddy, Nallamalla, request you to please come and take the dais. Diah, may I request you to please come and take the dais. And may I introduce Fuji Shu, Dr. Fuji Shu, Deputy Director Health, Country Office, China, at Bill and Melinda Gates Foundation, in a more complete form, because I knew she was going to be on this panel. Dr. Fuji is an infectious disease physician and an epidemiologist and brings more than 20 years of experience in public health research and program with a focus on infectious diseases. She's joined the foundation in May of 2020 as the Deputy Director of Health, China Country Office. Dr. Shu's career has taken her from public health sector in the United States at the Center for Disease Control Prevention to the private sector at the Gilead Science Inc., at the academics at Zhejiang University in China. I hope I got that pronunciation right. At the foundation, Dr. Shu helps the health team in developing innovations ranging from basic biomedical science to regulatory science, and is in implementing evidence-based service delivery to systematically advance the control of HIV, TB, malaria, and vaccine-preventable diseases. I now invite Professor Mala Rao, Director, Ethnicity and Head Unit, Imperial College London. Professor Mala Rao is the Director of the Ethnicity and Health Unit at the Imperial College London. She was the Director of Public Health in UK NHS in the 1990s, Head of the Public Health Workforce for England during 2004 to 2008, and the Director of Public Health Foundation of India's first Institute of Public Health. She is the chair of WHO's Southeast Asia region's expert group on environmental determinants of climate change and health, and has served as the medical advisor to the NHS England's workforce race equality strategy during 2018 to 2022. Her career spans public health practice, policy, research, and training, and her most impactful achievements have been in workforce development, strengthening health systems and environmental health in UK and overseas. Her research and advice to governments and global institutions have improved healthcare for millions, some of the poorest states in India and elsewhere. I now hand over the panel to Professor Murthy to please take it forward. Thank you so much.
Thank you. Thank you very much. After the last heart-to-heart talk between the two Dr. Reddys, both are cardiologists, so before they left the panel, they had a heart-to-heart talk. I'd just say that those who love cricket, this is the last 2 overs of the 2020 match, and those who like hockey or football, it's the last quarter, the extra time. So the most exciting bit is here. In fact, what we are going to look at in this particular panel is not what we've been talking about in terms of the public health system. We want to look at one of the major stakeholders, that is the providers, on an individual person-to-person interaction in terms of providing health care. So it's not just about the system, it's more about personalized health care, the individual health needs, and how that can actually be strengthened in the face of an onslaught like the COVID pandemic. I, for one, know from my experience in eye care that the first wave, a lot of children went blind because they were not screened for retinopathy of prematurity. A lot of elderly lost their vision because they did not get their timely diabetic retinopathy screening. The same is the case for routine immunization and many others, antenatal mothers not being screened properly in time, birthing being affected. So all these are aspects which COVID taught us, and the learning from this should be how do we strengthen the systems for the future so that personalized health care, even in the face of a pandemic, can rise up to the challenge. I think that is what this particular panel is going to deliberate upon in greater detail. We also had some of the context which was raised by Dr. Sanjeev when he was here. He talked about the family. And when we are looking at the healthcare providers, which is the context for this particular panel, you're looking at 4 different levels. The family, as Dr. Sanjeev mentioned, is one, with all the complexities which Dr. Bharat talked about. The community is the other one, and we've had quite a bit of conversation on the role of the communities. The informal practitioners, and we forget their existence. They are such a huge workforce, and we have not actually looked at their role within the context of a pandemic or an emergency. And of course, the formal healthcare providers. And even amongst the formal healthcare providers, you have the private sector, within the private sector, the for-profit and the not-for-profit sectors, and then you have the public sector. And if you look at that entire equation, it is skewed in favor of the private sector across most of the low and middle income countries, including the entire South Asia, Southeast Asia region. If you include the informal practitioners, nearly 90% of the health workforce or potential health workforce is in the private sector. If you take them out, 70%, 65 to 70% is in the private sector. And therefore, when we look at the requirements of the population, individuals within the population and the healthcare provider interface, there are many aspects which are unanswered, and we'd like this particular panel to look into that particular aspect. So the provisioning of healthcare is the primary function of the health systems, including the individual one-to-one interactions as well as the public health services. At the population level, we've seen the last 3 panels delve into that into greater depth. Now let's look at it from the individual perspective, the role of the provider. And here again we have maybe 4 different things that we'd like this particular panel to address. One is the service delivery, 2 is the role of the community within this interaction, the third is the learning. Was a lot of adaptation during COVID. Now how can that be scaled up if it is useful for routine health care and for future emergencies? And finally, to look at the monitoring systems which perhaps are required to look at how these different sectors and domains can actually be brought together. So this would be the sort of overarching aim of this particular panel. You have an excellent panelist group here, and against that context, what I'd also like to mention is that there is a lot of evolution. We are a dynamic situation. It's not that something that is decided today in terms of management remains constant tomorrow. Tomorrow brings in new evidence, and therefore there is a change. And therefore adaptation is very critical. So we should try and look at how this adaptation can be used for the benefit. There are opportunities as well as threats to the last session. The threats are most of the points that we had in our mind already discussed. So one thing we could do is, Dr. Reddy, thank you, and then walk out. The other is the opportunities that it provides. A lot of things have been discussed. So try and tease out what the gaps are there, and then try and look at answering some of those gaps. So let me first begin with MEC. Yeah. So should I give some of the questions that we had from MEC to you and some to Dr. Malla? If you were to look at the health providers' perspective, Delhi did something unique, the government here did something unique. They had this dashboard which showed the availability of competencies, the availability of beds which were vacant, oxygen, etc., etc., etc. So the population had an opportunity to look at, okay, where can I take somebody if there is a need because of this dashboard? But that's something which was not formalized and has not been used extensively. So Dr. Reddy, if you were to look at it, what are the sort of mechanisms that can actually help us to look at a facility register or making this sort of information available both to the other health providers as well as to the community? Can that be formalized? And would there be some objection from the healthcare providers, especially in the private sector? Dr. Reddy.
Yeah, I think that is one of the important component of the preparedness, I would say. So when we have the health status assessment, that leads to what is the health needs assessment. Then once we have the health needs assessment, then we look at whether the capacity is enough to meet these needs. But if the public health management or health systems management does not have this information on what is the existing capacity in the system, most of the systems have only information on what the government facilities provide. How many doctors are there, how many nurses are there. So that information is there in the public healthcare sector. But there is no such information in the private sector to the government. That means whoever is managing the health systems, we do not have that information. And one of the lessons during the pandemic, some of the examples like in Mumbai and other places where they could gather this information. Of course, it's not during the first wave, but subsequently, because they learned something during the first wave. So this information, and people learned what is the utility of this information in planning and prioritizing these limited resources when there is a sudden surge in the capacity, the demand. So in that context, I think if you look at from the Ayushman Bharat digital mission, the national level attempt to have information on facilities, on healthcare professionals, the diagnostic centers and the pharmacies. And also if you have information on what is the current capacity utilization, because one of the good indicator of demand supply gap is not the metric of 1 doctor per 1,000 or 1 bed per 1,000 population. It is what is the time I take to get my knee replaced? What is the time I get time to get an emergency consultation? What is the time I take to get an ambulance when there is an acute emergency? So that reflects the actual demand supply gap. It's not the absolute amount of doctors or ambulances per population. So if you have that indicator of what is the current demand supply gap in the system, then what is the surplus capacity in terms of utilization? At a facility level, I plan like that. When my average occupancy clocks 80% for 3 months, I create additional capacity. So that is at a facility level. But at system level, we are not doing that. We are not monitoring that. At what capacity the occupancy is there, what capacity is the surplus capacity, both in the manpower level, at the technology level, at the equipment level. So if you have that information, you can do, for example, during the Delta wave, there was a 20 times increased demand for oxygen across the country. So if you have the data on what capacity today we have and what is the utilization rate and where there is a surplus capacity, you don't require too much ad hocism in preparing for a sudden surge in the demand. So that's, I think, one of the critical preparedness factors. I mean, if we succeed through the ABDM, and if it is part of a greater public benefit of getting prepared to know this information, you have the legal mandate actually to demand this information from the providers, both the public as well as the private providers. Nobody can decline because it is an impersonal data. There is no protection. It is only the occupancy, what is the number. So that is not a information which anybody can decline. So it's only, I mean, this is one classic example of how you prepare your system for the future increase in the sudden demand, or you also simulate a model where there is sudden disruption to the supplies. I mean, you have the earthquake, you have the floods in the Pakistan, there is a sudden disruption to the supply. So that is another scenario. Then what do you do when there is sudden disruption to the supply? So this is, I think, a basic fundamental need for any preparedness of a provider system.
Thank you, Dr. Reddy. That's very, very helpful. In fact, taking that forward, if you look at the thousands of ventilators which were purchased by almost every state government in the country and which in the last 1 year have rusted, and even the scrap dealer is not willing to buy it. So if we are able to have a forecasting mechanism like you just mentioned, if Mumbai needed it first, because that's where the outbreak broke, and you have a central supply line, you immediately shift these to that particular location. And as the pandemic or surge started plateauing down over there, Delhi starts showing a surge, that excess capacity could then be transferred to a place like Delhi or Chennai, or it could be across the boundaries also, from Dhaka to Delhi. So is that something which is workable in the context that you just mentioned, Dr. Reddy?
In terms of the economics of creating surplus capacity to be resilient, there is also a compulsion to be efficient to become cost effective. Right? So in fact, that is the dilemma between efficiency versus resilience, because resilience demands surplus capacity, spare capacity. So there has to be a fine balance between the efficiency and the surplus capacity. The only way to be most effective is to have this information. There is no other way. Otherwise, exactly the example you quoted, there was a reactive response of giving oxygen plants to every public hospital, oxygen generating plants. And these hospitals don't have funds to maintain those plants during the normal times.
Absolutely. Thank you for that. Professor Mallarao, we observed that during the pandemic, most countries, they ramped up the physical capacity, infrastructure, beds, oxygen supplies, ventilators, and the example that Dr. Vijay mentioned about dexamethasone being ramped up at the community. But when you look at the users of that, the providers who needed to use that, there perhaps was a lack of competencies. They were overawed looking at that equipment which they had never seen in their lives. So what is it that we can actually do so the providers can deliver appropriate care, and how do we manage this, Professor Mallarao?
Thank you, Dr. Murthy. I think the short answer is none of us actually knows, because, you know, one of the things we haven't perhaps done yet is clarify to ourselves what sorts of shocks are we talking about here. It's interesting that much of the day has rested on the pandemic as our reference point. Well, the next shock, and we slightly touched on maybe the occasional earthquake or maybe the occasional flood or something. The next massive shock may not be a pandemic at all. It might actually be something completely unforeseen, as indeed the pandemic was when it appeared in 2020. The interesting thing is that we've had a pandemic, admittedly many, many decades ago. We've had a pandemic. Our epidemiologists predicted there would be another one, although they couldn't tell us exactly when. And even so, we were caught so unprepared worldwide. So it kind of begs the question, do we not now have to think, what shocks are we talking about, so that we actually build up the competencies you're talking about here? And in that context, you know, could I indulge myself and take the liberty for just a second to just share with you something that made shivers, you know, it actually created shivers down my spine when I saw that the World Economic Forum 2023 highlighted that the world is facing connected risks, threatening what they called a polycrisis, a word I'd never used before or heard before, a new descriptor to define the scale of the problems the world is facing. And the way they defined it is a situation when disparate crises interact such that the overall impact far exceeds the sum of each part. And I guess to some extent the climate crisis is the one that best, if you like, reflects a polycrisis. And we haven't seen it in its full unleashed capacity to destroy things we're taking for granted. For example, your previous question was, can we move equipment from one part of the country to another? I dare say if we had somebody from Pakistan here, and if we had asked them a question about a third of the country being in flood, as it was last year, I wonder what their answer would be about moving equipment from an unflooded area into a flooded area. I suggest that it would have probably been impossible, even if the staff were there. So, you know, the point is, we have, as human beings, I think, almost a limitation in our being able to imagine what kinds of risks we are talking about, and what kinds of barriers we might be facing, because our reference point at the moment is the pandemic, where at least that sort of thing didn't happen. If we had the trucks, and as long as we didn't have somebody dying of COVID, if we had a truck driver who was fairly healthy at that point in time, they could have physically taken a truck full of oxygen cylinders somewhere. But could it be that the next shock does not give us even that option? So, with that, to begin with, your question was, how do we build the competencies? And I think we're going to have to be incredibly imaginative. And I don't suggest that I have, anything like even a quarter or a tenth or, of that imagination. It's going to require all of us to think this one through. And I think the collaborative is in a very good position to get people to be a little creative in working out how we create some core competences, because we don't actually know what specialized competencies we are going to need unless we are actually good enough to predict those. And now in that regard, it was at Imperial College, my own college, that senior academics, as you probably know, because Dr. Reddy suggested we read that paper in advance of this session. And if he hadn't suggested it, I would have raised it anyway, because it is my colleagues who did some of that modeling of, how do we work out what the country needs. And in this case, it was England they were talking about. And they rightly, it seemed rational, they looked at staff, beds, and ventilators, because that's what, were the critical bits of the jigsaw required to be in place to have an adequate response to the COVID pandemic. And and what they did was to look at whether several interventions England brought in, such as setting up field hospitals, commandeering and buying private beds, getting retired staff to come back. Those who were still competent felt they could work in all kinds of different ways. Retired staff coming back, medical students being roped in to do some of the most basic jobs, fresh medical graduates doing some of the jobs that might otherwise have been done by, let's say, nurses, stopping all elective surgery and deploying all those staff into doing jobs that then release the critical care nurses to to look after just COVID pandemic patients. And they just about coped. The NHS just about coped, having done all of that. But then look at the aftermath of it. What about all those elective surgeries that were not done? And think of the burden that you end up with, and the additional competencies you require in the post-pandemic phase. You can't suddenly double your surgeons in order to take care of all the cancer patients who've been waiting for the past 2 years. And look at the tragedy of some of those patients who will definitely lose their lives. So going back to your issue of competences, the thing they found was the most critical issue was the shortage of critical care nurses. But then there's also the question of, you could double the number of critical care nurses in this post-pandemic phase. What about, if we don't face another pandemic, what do those critical care nurses do? So I like what you were saying in the beginning about thinking of ourselves as a group of people, not forgetting those complementary therapists, the alternative providers, the private sector providers, everyone with their areas of specialism in the mainstream care services, firefighters. Do you know, British Airways staff, these are pilots and the air stewards, because all flights were grounded, British Airways said, look, we're very good at hospitality. So why don't we come in and run your cafeterias in the NHS and so on, and give you the relief you need to cope with the fact that if staff were sick, as Dr. Reddy's panel mentioned, there's that other thing. If you've got your cafeteria staff all sick with COVID, you're not running a cafeteria. So British Airways staff came in and started propping up the health services. So how can we use our skills, not just within the health service, but even outside, in a more imaginative way. And how can we capture those learnings from the pandemic and sort of think to ourselves, let's not forget that there is such a temptation to creep back to this new normal, which looks kind of like the old normal, and going back to our respective jobs. You know, the airlines are so happy that we're all going on holiday and they can get back to their jobs. And how can we capture that learning and continue to engage everyone in the workforce in more imaginative ways, so that we can deploy people in all sorts of ways that future pandemics and future shocks might require. So, in fact, that would be my best suggestion.
Yeah, so this idea about co-creation framework for competencies where everybody could come together, this entire group here could deliberate on that, I think that's an excellent idea. Many of you may not know, Diah just came in at 1 a.m. this morning. So before she dozes off, because she needs the sleep, I thought let me go to her. So just following up on Dr. Mala's question or response there, in many countries you have, the reservation. They are the people who come in when there is a requirement, especially when it comes to law and order. So you have these volunteers. In India we have a group called Home Guards. Whenever there is a law and order situation or traffic has to be controlled, though they're not policemen, but they have been trained to manage that. Can we look at something on similar lines so that we don't create excess capacity? Like Dr. Mala mentioned, the surge doesn't come again. How do we utilize that excess capacity? Can we have these sort of volunteers or reservists as an opportunity for the future?
Thank you, and I would like to note that I love your comment about imagination. Yeah, there is a limit to our imagination, and I think this pandemic is, of course, it's bad. We don't want to repeat it again, but at the same time, it created such a destruction, that we were pushed to have a very vivid imagination on things we don't know. I think the push to innovate and to imagine a better environment is also being created by the COVID pandemic. Well, our imagination in CISD, I would like to point out to our imagination there, and perhaps also answer your question about reservists or volunteers. We had imagined something like that 10 years ago. Not volunteers, but young health professionals being called to serve for a limited time at primary healthcare centers in remote locations in Indonesia during peaceful time. When COVID happened, the same pattern was relaunched, but with a pivot into pandemic response. That first step then enabled the organization CISD, the government of Indonesia, in particular the government of the provincial of West Java, to imagine many more things and to create and build a new, not world, but a new reality that perhaps better for patients, but also for providers. So we push to have better primary healthcare, human resource at primary healthcare through this reservists that we call to action and to apply for a very short period of 6 months in a COVID response mode. And then afterwards, and we are still doing this now, transitioning into preparedness mode. So strengthening the health system, but dealing with the acute cases first during the height of the pandemic, and now that we are coming out of the pandemic, hopefully, we transition into preparedness as well. And of course, the biggest imagination that we attempt, that we innovate right now and still ongoing, is recreating the future of community health workers, working at primary healthcare centers as proxy of the health workers. So they were previously seen as a never-ending volunteer, an eternal volunteer. And I think that's just a wrong justification of getting away with not paying them with remuneration. So we reimagine in the future, I hope in the near future, community health workers can be seen as part of the health workforce as a human resource for health, which consequently asks them to increase their capacity through certification, not necessarily formal academic training, but certification, which then at this, when we try out this a model, it increases their capacity to do screening. It enables them to utilize digital tools to expedite their work, make it more efficient, make it more accurate. And based on this community-based strengthening, so our starting point is community. Based on this community-based strengthening, data, diagnostics, and medicines can be then transformed into providing better care for patients and also better experience for the providers as they are giving care. And it starts from community health workers up. So we are attacking two levels of health workers. One is the previously seen or still seen as volunteers, but then we are slowly nudging them up, increasing their hours to work, increasing their remuneration, asking them to involve more in planning, being able to identify vulnerable population, vulnerable groups with digital enabler, with very simple digital enabler. So I think that's the imagination and the starting point that Indonesia can offer to this learning collaborative.
Thank you. That's really, really wonderful to hear, because the reason why I asked that was I was in Sulawesi doing their childhood blindness situation analysis, and instead of policemen, at every traffic junction, you have these guys with sticks who show you where the parking lot is and collect money. So it's self-employment and you don't need the police. So maybe something like that could be of use over here also. But I think the point made by both Dr. Mala and Diah is the solutions have to be contextual. They need to be adapted to the local needs. I don't think they would be. You could have a generic framework, but the adaptation of that is dependent on the local context. So a lot of work which will have to be done at the country level to try and see what can be gained by a particular approach. Thank you very much for that. And Dr. Fuji, we haven't forgotten you. So let me come to you now. So one of the things... Welcome. So one of the things that we have been seeing is that there were a lot of interventions, innovations which were used during the COVID outbreak, the pandemic, which were basically emergency use authorizations. Even if the evidence was not there, but if somebody felt that even a margin of a difference, then it was pushed in, even with lack of evidence. But many of them, what the adverse consequences were in that situation were not looked at. And I would say including cost, because cost can also be an adverse consequence of a particular intervention. So if you have to look at bringing some of those interventions into mainstream health practice post the pandemic, into the regular mainstream health systems, what would be your suggestion of how this could be done so that we can mainstream some of those beneficial interventions and innovations which were seen during COVID pandemic? Dr. Fuji, over to you.
Thank you, Dr. Murthy. It's really happy to be here, listen to all the conversations. p.m. Beijing time, Friday. So I try to be brief. So you mentioned this emergency situation. I think the first thing first is you have to be treated as an emergency. So what you can and to do in that moment, in that facility, I think that really demands what is the necessary standards that you can respond with. I remember one of the saddest moments was like the doctors in Wuhan saying that they don't have an oxygen concentrator. They only can put out of 3 patients, severe patients, he would only be able to save 1 out of the 3. So that moment resides with me. Back in, came forward to, I don't know, the summer 2021, I guess, when India has a Delta surge that was huge. Our Indian office in the Gates Foundation reached out to us for oxygen concentrator. So immediately we put all my team, actually all of China office, the Gates Foundation China office into action and trying to source for oxygen concentrators. The number came to us that was very surprising. The numbers we said, okay, are you sure it's that high number? That kind of response we got. But anyway, so in those kind of memories, I would say, regardless on which setting, and I think that still come down to what tools you can use, what team you can rely on or mobilize, and kind of how to make the system work. The tools, I mentioned this, oxygen as one thing. Later on, we have a shortage of many things, vaccines and diagnostic tests. Even though with emergency use at the beginning, there was a short supply. And then afterwards, after the surge and many months later, there's a surplus. So I think the emergency use obviously should be going through a regular, the highest standard possible for regulators and for to check the evidence against the safety. And what is the evidence for for this drug can be helpful. But I think given the human nature, there's also a lot of people just scramble for things for hope. In the I don't know, you practice as a in the medical settings, in the terminal illness patients. We know a lot of things may not work, but there's still dignity and still hope, in this, whatever services, whatever tools we can give to patients, the drugs or things like that. So the teams is also, in the emergency, you don't have doctors, and that's a highest qualified. I think in the latest surge in Beijing, for example, in December 2022, every doctor in the hospital instantly become a respiratory health, not really pulmonologists, but actually their ID doctors immediately. But they could be, their day job in the past could be surgeons, but then instantly transmit into a medical team that can, providing care the best they can. The last thing I want to say is that the moderator shared, I work in the government, I work in the private sector, I work in the university, and also lastly, I work at the foundation now as a founder perspective. I think how we can make the system better is it's need to think about collaboration and the sense of trust. If people can share data, even though you make the wrong decision at the beginning, you can learn from each other through collaboration and getting the information as quickly as possible. Actually, I was responding to SARS-1 back in 2003 in Beijing. So that was, so I was the lucky one responded to COVID infection twice in my life. I think that was early on, there was not enough learning to see what actually works. And retrospectively, we say, people were putting on either the wrong dose or the wrong treatment. But that's just a big, I think, reflecting the lack of collaboration, between hospitals, between countries, between international agencies. So I would think it's hard we all humans, we have to guess at the emergency. We do what we can, but But if we have the spirit of collaboration, we'll learn as fast as we could. So that's my response to your question, Dr. Murthy. If you allow me to say another thing, which is the practice and practice. On top of the collaboration, I think the practice is also good. For the different teams or different countries or different agencies have a different type of thresholds or different views on things. So if we can, in the peacetime, we can practice and talk this thing together, and then we train ourselves and look at it, learn from others' perspectives, I think we could be all doing better in the next emergency we don't want to see. Over to you, Dr. Murthy.
Thank you so much. And for the entire panel here, I have, based upon the response here, I'll just have one question, and I'd like the entire panel to think about it. We had emergency use authorization. A lot of things were permitted. It's been about 2.5 years now. Has any of that been withdrawn because of lack of evidence? If you have any idea. I don't know of anything being withdrawn which was provided emergency use authorization, even without evidence 2 years down the line, starting with Professor Reddy.
Yeah, at least, to my knowledge, there is no drug or vaccine that has been approved has been withdrawn. But having stated that, in terms of the post-marketing surveillance that is required of a vaccine, we may not have that adequate data, robust data that normally we demand during the normal times. And that is leading to actually some of the concerns, some of the misinformation that is still floating in the social media about, recently when you look at some of the spate of deaths, sudden cardiac arrest deaths in young people coming daily in the newspapers. So the social media gossip is that it is because of the vaccine. So that's where I think what worked as an emergency use authorization and what can be taken as a new normal in terms of accelerating approval of some of the innovative drugs and the vaccines, but at the same time how to also balance some of the areas of security that we might have overseen because of the emergency nature of authorization. So that is a brief comment and a reflection on what in the new normal state, some of the good things of that rapid vaccine development. In fact, now the target is 100 days development. But how to put systems still in place so that we don't make a mistake.
True. Yeah. In fact, that point on new normal, maybe new normal is more normal than the old normal. So it's actually a dilemma. Yes, sir.
I have a very specific,
I'll just come to you, Dr. Fuji. Yeah, please.
a very specific response to your question. The answer is we have withdrawn medicines in the U.S. We withdrew hydroxyquinone. Okay, so that was definitely withdrawn. It was EUA approved and withdrawn. We've withdrawn almost, I think, all at this point the recommended use for our antibody therapies because the virus is mutated. And practically, we've withdrawn the adenovirus vaccines that you've used so widely here. We never approved it in the U.S., the vaccine that Serum Institute produced. Europe has eschewed that vaccine after adopting it. And I would recommend India do the same, although I think that's very unlikely. I think it's a big mistake to continue with that vaccine.
Actually, the point that you made, I really need to congratulate the US President because he helped the Indian economy by buying all the chloroquine that was available in the country or not available. So we need to thank him sometime or the other.
That's a little ironic, isn't it?
Dr. Mala.
Well, I don't know that I was thinking about the U.S. actually when you were talking about withdrawal, but the point has been made. I I wonder whether we may talk about ways of working rather than just drugs. So what has been approved was your question. So of course, you know, approvals go beyond just medicines. It's about ways of working. Because certainly, very dramatically, the whole world of telehealth changed in Britain. The family physicians, you know, as the world knows about the value and almost the affection that communities have for their GPs, their general practitioners, on whom much of the NHS and its efficiencies and so on depends. And the whole point is the GP is seen as a local resource. People go and talk to them, and they know the family well, and so you may go in with a pain somewhere, but they're going to be able to see that in the whole context of your history that they know, and the family that they know, and make the best diagnosis for you. Now, much of that has become teleconsultation since the pandemic, and it has not reverted to the old way of working because there are acute staff shortages. The pandemic did other things, as you said. You know, unforeseen consequences are staff burnout. Staff have left the service. Huge numbers of vacancies. So all parts of the NHS are suffering because of the shortage of staff, including in general practice. And so teleconsultations have been seen as an efficient way by which they can continue to manage the burden of consultations and referrals into them. We've never properly studied what the effectiveness of it is. Maintaining teleconsultation, on the face of it, it looks very efficient, but are there downsides that are hidden and we don't know about? The other point I'd like to make is about education. When I was at the Indian Institute of Public Health, before you took over, Dr. Murthy, in the 3 years, one of the things that used to really upset me was this notion of the global north always having and wanting face-to-face conferences, because I think that that's a luxury the global north has. You have the money to pay for your flights, you have the money to set up your venues. How many people, how many young aspiring postgraduate students, undergraduate students can travel to Washington or London or Vienna or somewhere for a meeting? And look at the way our method of continuing professional development has, I think, excluded large numbers. The sudden and almost overnight hybridization of education, of conferences. We never think of conferences now without thinking of them being hybrid. Look at the way you've been able to, without flying them in, we've been able to have the privilege of the views from Beijing, Singapore, and all sorts of places as a result of this thing that has come in as a result of the pandemic. Right. And I think we haven't studied it, but I'm a great admirer of how that has changed, and I hope we never go back, because it has equalized access to events and learning across the world in a way that didn't exist before the pandemic.
Completely agree. So, Diah, your comment on that, emergency use authorization, if you think there's something that you'd like to add, something which has been withdrawn. Of course, it's not emergency use authorization, but things like use of masks, those have been withdrawn, but they're not emergency use authorizations. So anything else that you'd like to?
Yes, so many things in my mind triggered by your comment, Professor Rao. But for going back to our topic of delivering the care, I think drawing back from my country experience, a lot of resources and budget, especially in the beginning of the pandemic, was put for PPE and for diagnostic tools. And then it shifted towards vaccines. In all, throughout, I haven't seen resources, serious resources being put to increase the quality of the providers for the health workers themselves, especially for the community health workers. That's one. I think I would like to make a comment on that, because when we talk about health system strengthening, how to build resilient health system, we talk about the system as if it doesn't consist of human capital, while they are the true operators that make sure the system works. So, and they fall through the crack. So if we have to determine in a new normal, we cannot go back to not investing in human capital. So that's a new way of thinking of putting investment into health sector development, and also about breaking barriers and boundaries, inclusivity and diversity. I've heard in one of the panels, the pandemic fund was mentioned as a result of the Indonesia G20 presidency. I think one of the historical breakthrough in that pandemic fund is allowing civil society to be in the governance board with voting rights. And we cannot go back into a situation where it is not. As Professor Rao has rightly put, it should be open to everyone, especially younger professionals, so they can have access to learnings like this. And I say that based on our experience, because we engage, since our inception as an organization, we engage with youth, with young people, and to break down barriers for vulnerable population and for women and young adults. So I think that type of learning should be fostered more, and I would love to see younger health professionals replacing us here in learning, in sharing their experiences. Thank you.
Excellent. Dr. Fuji, before I come to you, I'll ask Dr. Reddy. There was a yoga guru in this country, in India, who came out with a drug called Coronil. No emergency use authorization. It was used. And then the only retraction was the name of the drug, or is it still available, Dr. Reddy?
No, the fact that there are so many unauthorized drugs available, accessible, both traditional as well as modern medicines. So the brand might have been withdrawn, but I think the drug is available.
Still available. Dr. Fuji, over to you. We mentioned one drug from here in India. Anything like that in China or any other?
It's actually many. The Chinese treatment guidelines have evolved into 10 different editions. So I would say that's a professional consensus that's evolved into 10 editions now. So many things fall into the wayside. And Dr. Reddy mentioned there's many traditional medicine was put into early treatment, but when better antivirals and, even among the antivirals, that is the evolution, which one getting the data support and then getting better use or widespread use. So I want to add one more thing into the preparedness. Actually, I think I can speak, I'm not quite sure this is the public information, but actually right now there's a debate within our organization. So there's so much need for global health. And whether we put that dollars into prepare for the longer term, which means stockpile or, capacity building, training young people, for example, this is really for the future. But right now, we one of the speakers mentioned just another session saying that is, in African countries, in many developing countries, there's an urgent need for getting built back the things that is fall apart, either because of lack of funding or lack of other issues. Like that can be including early immunization programs in women and children, reproductive health issues. So I think as this group, I really I want to hear, if you may, Dr. Rao, Dr. Reddy, and Dr. Murthy, give us some feedback on that. I know this one the speaker mentioned, the preparedness fund only $1.6 billion, even though we think in one of the Bill Gates' book, they said even only for the medical, they call it a pandemic corps. Basically the global response team with 3,000 epidemiologists, but maintain that workforce, that team, a global team, they need about $1 billion per year. That's 3,000 epidemiologists at the, globally. So where we should put our resources to right now? Over.
Thank you so much. Dr. Reddy, coming back to you. In most of Southeast Asia, South Asia, most of Africa, in fact, most of the world, the private, both for-profit and not-for-profit sectors are the largest providers of healthcare. But in terms of involving them or skilling them for emergency preparedness, there seems to be a big gap. Either because the public sector doesn't have that trust, or there's a lack of interest from the private sector. But there is a gap there. And this gap is not beneficial for anybody. So how do you think that we can get over this, bridge this gap, and how could they be brought into their participation in the future?
Yeah, one reality is that we have to live with the mixed health systems. And we may not be debating why this situation has arrived at because of the failure of the public system. That the private system emerged to meet the unmet needs of the people, because the public system could not meet the needs of the people. So having said that, if people try to look at what are the key strengths of the private sector and what are the key strengths of public sector, I think the whole distrust is because of no attempt at understanding each other and accepting each other. The private sector looks at the health needs of the people as an opportunity, not as a responsibility. The public sector is responsible for the health needs of the people. So it is not an opportunity, it is a responsibility. So that is a fundamental difference. I think we have to accept that fundamental difference between opportunity versus responsibility. And by for-profit private sector, market segmentation is part of the business ethic. That is, every business school only tells how do you segment the market and how do you position yourself for a particular segment based on your core strength. So having said that, you have to accept that private sector cannot be equitable, because by very nature of business, they do market segmentation. But so this acceptance is important. I think because we don't accept that and because we want them to be responsible, we want them to be accountable, that is where the distrust comes. But when you look at the strength of the private sector, I mean, private sector being small to medium, I mean, the large size private sector is only accounts for 5%. And 95% is micro to small to medium. Usually it is promoted by the professionals. So being small to medium, the private sector has a unique strength of being highly responsive to the people's needs. If the people want care at home, they respond. If they want sampling at home, they respond. If they want you to see them in the midnight, like in the old city of Hyderabad, because that is the culture, they have the clinics open in the midnight. So that is the responsiveness of the private sector. Similarly, the agility of the private sector is much, much higher compared to the the monolithic, the public sector organization. So why the private sector is agile and responsive is because of its decentralized autonomy. Right? The same autonomy, if it is given to the public sector in terms of the decentralization at operational level, then it can become as agile as the private sector. So that is the lesson that they can be taken. The second lesson that can be taken or exploited is the private sector by design, because you need to maximize the profit, you have to be highly efficient. That efficiency is driven by the private. So how you leverage that efficiency of a private sector? By smart purchasing, where public sector is unable to provide services. Not all services, but unable to provide services, you purchase from the private sector. So this is where I think the third element is whatever policy formulation and policy implementation is there. I think in the morning we started off with just relationships and the communications and the engagements. If private sector, if civil society is taken as part of the governance system, they are not separate, they are part of the governance system. So whatever laws that are applicable to a private sector provider, they are applicable to public sector provider, but that's not so. So there has to be this engagement and involvement to build the trust, while accepting the fundamental differences between the private sector and the public sector. So that actually makes you to share the data for surveillance, share the data for preparedness. You will be willing to actually nationalize your facility during an emergency for the defined period. But you define the period. Suppose you just nationalize it and force that you have to only charge this much during a pandemic. They will have 100 excuses to violate that. So one part of the preparedness is how you keep engaging the private sector while accepting that. So I think this is my, because I worked in the private sector, again within the private sector, the three dimensions of private sector, for-profit, corporate, private equity-driven, maximizing the profit component, then a professional-led, entrepreneurial kind of a self-employment, nursing homes and small hospitals, they are different. They don't violate the medical ethics. That is still priority for those hospitals. Right. But the for-profit corporate hospitals, the business ethic overrides the medical ethic. That is the conflict. So that means you need to have a kind of a differential funding, capital funding for the private sector than the current method of private equity funding. I'm telling from the experience that we have gone through, how it, when we lost the control to the private equity, the business ethic started dominating. So these are some of the actionable policy things. The government to create a funding mechanism to help even the private sector, where the public sector is unable to achieve those levels of efficiency and effectiveness. These are few reflections on the private sector engagement and how it should be leveraged as a part of preparedness.
I think that's a very valid bit, because when you look at a state like Karnataka next door, initially they had a problem with the capacity. And then because the government engaged with the private sector, brought everybody together and said that we need this and we'll pay you for this. So they were not losing out by sharing. I think that is the point that you're making, that don't burn a hole in their pocket, take them together, and maybe that would be the way forward. Stemming from that, Diah, I have an interesting question for you from what you mentioned in one of the earlier panels, and that was, the need to spend more on primary health care. You had mentioned that in one of the earlier sessions. And you have to get the government away from the tertiary and specialty healthcare funding to bring in money into the primary health care. So would it be an interesting concept to get the private sector invest in the tertiary and specialty hospitals, and the government buys the service from them, and whatever is saved from that expenditure on a government ivory tower, that goes into primary health care. So immediately there is freeing up of some money. The private sector, they create the capacity, and their services are purchased by the government to provide the services, while money goes into the primary healthcare network. So would that sort of a thing work, or do you have any other suggestions?
Well, any model can work, basically. But I think first, the homework of the government is to create an enabling environment where there is a tangible incentive for private sector to want to be in primary healthcare. In Indonesia, when we first got our national health insurance mechanism, healthcare suddenly becomes an opportunity for profit, especially if you set up a private clinic or if you set up a hospital. I think both needs to be looked at differently, and I think what we need to do for primary healthcare is to first integrate public service and private clinics. So integration of care needs to happen first. As to from where the money to invest must come, it doesn't necessarily have to take the government away from the tertiary care or secondary care, because the amount that is needed for primary health care to transform itself, or the amount of investment required in primary health care, will never be as huge as the amount of investment needed in tertiary and secondary care. So it doesn't necessarily bring government away. So of course, we as a country, as a nation, right now you have to compete, and in healthcare, the competition, so to speak, might be in the level of tertiary and secondary care. However, on the flip side of that, if you as a government or as policymakers are able to set up a mechanism in primary healthcare in which you provide quality of care, I think that's also a win for the government. The model, I will use Jack's lines this morning when we chatted briefly. It can be anything. We can try whatever works for any country. But the principle, the fundamental of investing in primary healthcare, I think needs to be agreed upon at the highest level possible. And then, of course, by that, well, we have our consultations with providers of private primary healthcare providers, and all comes back to us by saying we do not feel that there is enough incentive, and this is not necessarily financial incentive or an incentive, financial or otherwise, for us to be in the primary healthcare provider as primary healthcare provider. So I think that's the biggest research question, if you will. If you are a policymaker, what will draw the private sector to want to be in primary healthcare? Because then is integration of care one, perhaps? Is division of people who are in the list to be provided care, perhaps, or a combination of both?
I think that's an excellent way of looking at the situations in different countries, and I think one can keep deliberating on what is the best model there. Dr. Fuji, I haven't forgotten you again. One of the things that came to the fore during the pandemic, and even after that, the last couple of years after the major surge came down, plateaued down, is the mental health aspects. And I think across the life spectrum, whether it is children, whether it is the elderly, whether it is the working couple, everybody had some amount of mental health issues. Now, when you look at the mental health workforce, on the private side, capacity was not built too much because it was not felt to be something which is going to be paying back in extensive ways. But whatever capacity is available in most countries has been in the private sector. So how do we look at bridging the gap between private and public health providers in terms of the huge need for mental health services and the current lack of these services within the public sector? And this is right across all countries. Dr. Fuji, if you have some suggestions on that. I think she's...
Yeah, Dr.
yeah,
Murthy, I'm sorry. You can hear me, but I don't have any answer. My answer is I don't know.
Okay.
The question and the challenge, you describe it very well. We can feel that in a big city or small city, in school, in elderly and population, it's everywhere. But people are responding. That's the only thing I can add. People are big, schoolhouse and all community house. Everybody is trying to do something about it. But in the short answer, we have to wait and see what happens what can be done to this huge problem.
Thank you, Fuji. Yeah, you were saying something, or was that?
Yeah, I said one thing I wanted to point it to. It's obvious, right? So this COVID-19 is probably the only ever we know of in history, recorded history that is a truly global issue.
So I think Dr. Mala would take that question on, and maybe I'll ask you the follow-on question also after you finish answering this.
Yeah. Dr. Murthy, thank you for giving me the opportunity of just sharing something that I learned only in this last year or so. One of the things that happened was that we came across, I think it was BBC, which did a survey of young people, assuming that COVID, this was during the pandemic, that there would be huge proportions of young people extremely worried by the pandemic, and they were. But an even higher proportion, even during the pandemic, were concerned about the climate crisis and the fact that the pandemic had ended up diverting resources away from what they saw as, up to 2019, some kind of a progress where adults in their lives were beginning to do something about the climate crisis. So that was just one interesting fact. And then last year, I was asked to guest edit an international review of psychiatry, themed edition on mental health and the climate crisis. And in that regard, although it was the climate crisis, and it wasn't specifically to do with the private sector, there were amazingly good, and what I mean is informative papers which taught everyone so much about the kinds of progress Bangladesh and the Philippines are making to deal with exactly that. How do you deal with the burden of mental illness when you have such low levels of resources, even when you count in everything that's in the private sector and almost a non-existent resource within the public sector? And what they've done, of course, in Bangladesh, they've gone and in the Mujib prosperity plan, mental health is part of it, and the government commits to investing in mental health. Now that's impressive, and I've been waving this in Britain and saying, look at what Bangladesh has done, and I think Bangladesh has been a beacon in saying mental health has been sorted. Their entree into it is to see how much the climate crisis is affecting mental health. But whatever the reason, they've gone and made that one of their priorities. And in the Philippines, they have developed incredibly imaginative ways by which the lay public have been brought in to do mental health first aid and do some of the, the early identification management of mild to moderate anxiety disorders in the community through community support, ensuring that isolation, isn't a problem of elderly or people living alone, and all those sorts of things, and allowing through this task redistribution the best trained psychiatrists and the psychologists to do the training, but then also to be the people who look after the most seriously ill. So there are 2 or 3 countries in the global south that are pointing the way to the whole world on how to manage this crisis in mental health care.
Wonderful. I think that's something which brings in optimism on the global south providing some of the solutions, and if Dr. Reddy could try and look at compiling some of these as part of the Global Learning Hub, I think that would be a great opportunity. Dr. Uma was just whispering in my ear from a distance, she's whispering that you won't get a shot of tequila if you don't ask a question. So now it's over to you. If you want to earn your shot of tequila, you will have to ask a question. It's audience questions now. Yeah, please.
Yeah, I have it's not a question, it's another general comment. I think if we're going to talk about things that worked and things that didn't, like the EUAs in this, we have one big area that nobody's touched on, and that's the law. In my opinion, COVID has been disastrous for public health law, certainly in the United States. Things that we were able to do, mandate, we can no longer mandate. And I think that's something for all of us to take up. I'd like to see a forum on the law and public health and the consequences of COVID, because we are in a much weaker position. And the law is eventually what allows you to do anything. You pointed that out with the EUA, but the law for mandating masks, the law for mandating lockdowns is so much weaker than it ever was before. And that is part of misinformation, it's part of the whole thing. But when it gets codified in law, it becomes a lot more permanent. And that has happened in many, many cases. And I think it's something we in the public health community have to take very, very seriously.
Right. Thank you very much. And unfortunately, because there were no questions, so tequila has been withdrawn. So over to you, Uma, for the concluding. Thanks to the entire panel here. Dr. Fuji, Om9, thank you so much.
We can't afford to right now at the time. I also cannot wrap up the session the way I would like to, but I would just like to focus on the fact that the private engagement did come forward in more ways than one during the pandemic. The central supply line is a wish list. The reactive versus the proactive is again something that we need to look at. The cross-functional skills that we spoke about is great to have and is aspirational. We have a lot of contextual approaches that we need to look at, local, global, local, and how back at home that we can look at. Mainstreaming some health practices, again, something that we will work on. What has changed since the pandemic? Both the education and the way that we have looked at life has changed. Today has been an interesting day of bringing together several thoughts, several panels, several experts from over the globe that have come together to share their thoughts and their learnings. We've had a very engaging audience in terms of making their notes, and we're looking forward to hearing from them as to how they would like us to engage with them as we take all these conversations in simple formats into learnings and also make those available to all those who are interested and also in need of it. Recognizing a panel, I'd like Minaz to come up. Professor Murthy, while I would like to do the honors for you.
Thank you.
May I request you to do the honors for the others?
You don't come here because she's blocking us. I need a photograph. Oh, okay. We'll come to the front. You can.
Yeah. Thank you so much.
Grateful to each of you who has spent the day with us and who will spend the evening with us. We may not give you tequila, we'll give you other stuff. And we will head down to Juniper, which is an open air area and also an inside area, where we will have our dinner. So from here to Juniper is a short walk, and there will be people who will take you there. Looking forward to seeing you there right away. I would be failing in my duty if I didn't ask you to scan the QR code and make sure that you answer the poll questions and also our feedback for us. Learnings that are important, and an important part of the learning journey is something that we look forward to taking back with us. That poll is vital to making that happen. Please do make that effort. Do fill in that poll. Do share it with us. Thank you for today, and we'll see you back tomorrow at 9 a.m. like we did today. Thank you so much. Your group photograph.
Oh, group photo.
You have to